oh no, that's not even, Pepcid isn't even over the counter. Like we need, prescriptions for famotidine, and we need to justify it. And I mean, Pepcid, our docs in the clinic, like Pepcid is one of the first tools they reach for. So it does. I'm not gonna say it doesn't cause cause some issues.
But a greater degree of professional autonomy, you're suggesting, is needed to deal with some of these more complex conditions.
Exactly.
Exactly. Fantastic.
Yeah.
David, you've been really generous with your time, and I'm aware we've had a fair bit of it. I have, if you do have time and inclination, I've just got 3 or 4 questions from general public who and they've emailed them in advance. I'll try and fit them into 10 minutes max, and feel free to give short answers as you wish, but I would really like to allow them to be heard if you wish. So a question here from Michael: how do we stop the conflation of fatigue and PEM, or post-exertional malaise, and how do we get that acceptance that PEM is a real phenomenon?
Education and research. A lot of the educational sessions that I take, I really break down the difference between fatigue, sleepiness, exercise intolerance, and PEM. Those 4 constructs, and I say these are how they're different. This is what it is, and these are ways that you can measure each one. Because I think that it is an educational failure. I facepalm myself at some of my early long COVID papers because I was just talking about fatigue. I didn't know what PEM was. It's a distinct construct. And then I think in terms of how do you show that it's a real physiological thing, we need more and more research on that. But I mean, in a fair world, in a just world, the work that Rob Wust has already published on the way that muscle fibers in people with PEM respond to submaximal exercise, the way that mitochondrial processes change in submaximal exercise, it very early switching over to anaerobic ATP production that cannot be explained by deconditioning. And his recent work, which is pre-printed but not published yet, is beautiful in that regard, where it shows truly deconditioned people who have been on bed rest for 3 months, as part of like NASA and space studies, not having the same metabolic responses to exercise as people with PEM and long COVID.
So important.
I'm really hopeful that the good work being done by folks like Rob is going to turn the tide on that, because already I think the evidence is undeniable. We just need to get people better understanding the evidence, because a lot of folks don't understand exercise physiology.
David, you're making me far more hopeful than I was expecting to be.
Good.
A question from Elka: what do you think is the relationship between long COVID and ME?
So I think that long COVID and ME both hold their place in infection-associated chronic conditions and illnesses. In fact, I would even say, I like to say, and everyone hates when I say this, but I like to say infection and exposure associated chronic conditions and illnesses, because I want to make room for the fact that Canadian consensus criteria, which is what our clinic uses to diagnose ME/CFS, can be from a car accident, can be from a surgery, can be from,
other forms of trauma, or stress response, or immune response, and we think about it as these sort of recurrent immune challenges, these successive hits that can then kick you into this disease state. I do think it's important, even if you have a long COVID and an ME diagnosis, I think it's important to retain that long COVID diagnosis, because I personally believe that from the literature that both we've published and others have published, that the pathogen that infects you matters in a reasonable subset of people.
And so knowing that you have long COVID, knowing that COVID was the index infection that triggered your illness, could be very important to your treatment.
We don't know yet know its full significance for future understanding and treatment.
Exactly. And so that relationship, I think, is really important. I also think that we can learn more by studying everyone under one big tent. And I happen to be, we've all heard the sort of adage of there's lumpers and splitters. There's people that lump everything together and there's people that split. I happen to be a splitter. So what I want to do is I want to bring everyone under one tent. And then I want to say, well, how many groups can I split you into now that we're all under one tent? Now that fibromyalgia, ME/CFS, chronic Lyme disease, babesiosis, long COVID, you're all under one tent. Now let's start to, okay, you've got reactivated viruses, you've got persistent COVID, you've got POTS, let's figure it all out.
David, you're a philosopher at heart. You like making distinctions. I can see that. I understand. I know the feeling. I've got a question. Thank you so much for that. A question from Lindsay regarding dysautonomia and gut issues, especially for those who cannot absorb nutrients well enough, either through slow transit or not getting enough food in. Has any progress been made with those conditions or issues, and how do we halt the progression to feeding tubes?
Yeah, I definitely think we need better understanding of gut motility issues in this cohort. I do think progress is being made, and I do think that the research that has been published around this, and full disclosure, this is not an area that we study a whole lot, but it is an area that we're very aware of. The progress that is being made really is pointing us in the direction of small fiber neuropathy driving gut dysmotility. A lot of the biopsy studies have shown that the gut tissue that they biopsy is aganglionic, meaning that in many cases, by the time you have full gastroparesis, meaning your gut isn't moving, if they take tissue, there's no nerve cells in that tissue. So that tells us that small fiber neuropathy is at play. And so that's when we start to think about, okay, well, what can we do to heal that small fiber neuropathy? So I'm really interested in David Systrom's work with the LIFT trial, looking at low-dose naltrexone and pyridostigmine, because these are this combination of drugs which Systrom at least believes is restoring small fibers both to blood vessels and to gut, is potentially something that is really hopeful there in that area. I think with caution, with appropriate caution, because people can have very bad reactions to this. And typically what, the general advice is making sure that your immune system is in a state to tolerate this. But with appropriate caution, there have been publications talking about the use of rituximab, a B-cell therapy, to calm down inflammation enough to allow for small fibers to grow back. If the idea is that neuroinflammation is destroying these small fibers. And then I'm also just, watching the work, and I'm hopeful about the work around FcRn inhibitors, which are a sort of special class of very targeted immunotherapies that can address some autoimmunity that could be causing small fiber neuropathy. And so alongside FcRn inhibitors, I'll also say IVIG, is one of these sort of one of these interventions that I think about with gut motility. But it's such an important problem, but I do think there have been some really good publications in the last 5 or 6 years moving us in this direction.
Brilliant. I could say more on that, but we're going to leap into our last question so we can round up. And it's a question from Sarah. How do we get better support
and diagnosis for conditions like MCAS. GPs here, general practitioners, seem ill-prepared for some of the conditions and the sort of comorbidities that COVID is generating.
Yeah, this is a tough one. I mean, I am frequently heard saying that we need better MCAS biomarkers, and I have no idea how to deliver on that, frankly, just because, you know, it's not my real area of specialty, but, you know, we find, you know, the published literature tells us that 50% of people who respond strongly to antihistamines and mast cell stabilizers have normal histamine levels and MCAS markers. So like, there's a whole bunch of, you know, a bunch of like allergist, you know, journal data to suggest that, like, yeah, what we have isn't working.
Yeah.
So that's a problem. I also think that we need a lot more research into the role of hormonal health and histamine issues. I think you can be blasting yourself with antihistamines as much as you want, and if your estrogen dominance is out of control or your DAO levels are all over the map, you are still going to have problems with removing histamine from your body and producing too much histamine and all of the other inflammatory problems that mast cells cause. And, you know, right now it's just such an understudied area. So I'm really, again, you know, to be encouraging, I'm very encouraged about the fact that we have large funding agencies like the Cohen Foundation who are announcing huge women's health initiatives around hormonal health to dig into these issues, because they are such a cause of cognitive impairment, migraine, daily disability, and in many cases, antihistamines alone or mast cell stabilizers alone without addressing that hormonal component won't get it done. So I know I didn't answer the question there, but
no, you did. You recognised the difficulty of it and where some of the barriers are and what some of the leads are and some of the difficulties in addressing them. I really get it. And David, I mean, I think we should wrap up there, but I just want to, that kind of leads me to something else. You know, I hadn't expected to feel as emotional as I do at some points during this interview, and I'm just reflecting on that in light of what you just said. It's because you've spoken to us so knowledgeably, open-mindedly, passionately, and kind of intentionally about addressing, about understanding and treating these conditions, and you've moved your way across the cobweb, this incredibly complex web of of different symptoms and barriers to understanding and possible lines of inquiry, and I and so many people are just not used to hearing it. We don't hear people weaving the web like this and bringing it all together, and it is moving to hear someone do that in the way that you have. So on behalf of all of myself, and everyone listening, and many people out here listening, thank you so much for that, and for the way that you're bringing that into your tireless work in clinic and in education as well. And from all of us, absolutely more power to you, and we want to hear a lot more of what you and others have to say in this direction. And and thanks for being so generous for your time today, but really for your tireless work for everyone with post-acute infectious conditions. Thank you so much, Dave.
No worries. Thank you for having me, and thank you for doing this. This is so important. So I really
my pleasure, and it'll go out on Long COVID Awareness Day today, and it'll be a great way to mark the occasion. Thanks again.